I'm Arun Srinivasan. I work in the Children's Hospital of Philadelphia, and thanks for this opportunity to present to this elite group and this wonderful endeavor for pediatric urology. So I'll start my video.
You're on.
I'm on. Okay. All right. Very good. So thanks for this opportunity, as I said. And my topic is going to be about controversies in VUR, which essentially could be a number of possibilities. So VUR is one thing that has swung from one end of the curve to the other, and thus brings itself to a multitude of possibilities in terms of controversies. So I've chosen purposefully to stay away from interventional possibilities. So I don't want to talk about deflux. I don't want to talk about robots or a laparoscopy or anything much more broader, 40,000 feet view of VUR, and say there are two things that are still unsettled. And one of them is the need for intervention in a child with reflux, and VUR and antibiotics as a recent controversy after the American Academy of Pediatrics recommendations. I have a few slides, so I'm going to try to go for it in a little faster manner, but please slow me down if there is anything in question. So how big a UTI is a problem? How big of a problem is UTI? And this is basically, we have 5% of all children who present to the emergency room in the United States with a fever have a urinary tract infection. And that sort of comes down to about 200,000 children every year. White children, for some reason, seem to have a higher prevalence. And girls obviously have higher incidence of urinary tract infection than circumcised boys. And definitely some of them do have scarring and kidney damage, and some of them eventually may end up, although this eventuality is much rarer now. But still, I've seen one or two over the last few years that have ended up here. So it's definitely possible. So to track what we're doing today, we definitely have to look at history. And this is one way of looking at it. So we threaded back all the way to 1964 or 1960s, really, when Hodges and colleagues basically said, well, there is an entity called VUR, and it can increase the risk of a urinary tract infection, which eventually can cause scarring. So our tenor has been since 1964 that reflux plus a bacteria means renal scarring secondary to a urinary tract infection. So if this is all the children we have, and this many children, which is will have urinary tract infection with UR, if this is all the children with UTI, and this will be all children who will have reflux, and it's about 40% of them, and a third of them will end up with renal scarring. So the kids circled here are the ones to find out, because that's what we eventually care about. So the trick is how we're going to do it. We can just do all or none, but neither of them are going to be optional choices. So then you say, how do we pick up these kids who really need to avoid the renal scarring? And these are the kids who really need the surgery. So then eventually a surgery was found out. Dr. Politano essentially proposed the first reflux surgery back in 1972. And we figured that actually works. So if we stop the reflux, it stops the paradigm. The paradigm is broken, no renal scarring. Open ureterocystomy turned out to have a success rate of 99%, excellent operation, minimal comorbidities, and say, yeah, let's all go for it. And that's essentially what we did worldwide. In the US alone, if we translate that to today's expenses, it comes to about $1.3 billion, 200,000 VCUGs, 50,000 reimplants, and 3,200 gallons of Bactrim consumed in a year. So that obviously, it's an excessive amount. And that soon we found out that everywhere, all around the world, we were pretty much overwhelmed because there was simply too many kids with UTI and VURs. And Jean Smelly comes out with her antibiotic prophylaxis theory, and this is where we got. So then you say, okay, maybe we shouldn't fix all of them. Maybe we should just give them antibiotics. And that seems to be a great option. So that turned out to be this, which is less expensive, but still it's about 25% of surgery, 38,000 gallons of bathroom. So the bathroom consumed went up significantly higher. And that made us wonder. And again, that doesn't sound like a great option, and particularly for kids and parents who got pretty nervous with the amount of antibiotics they're on, the number of VCGs we were doing. And then came more important knowledge about reflux. One thing, it gets better on its own. A multitude of patients, it does get better on its own. And if that's the case, and this is our own data, which was presented back in 2002, data between 1980s and 1995, and you see the Kaplan-Meier, the lower grade refluxes almost always resolves. So the second data comes up when a multitude of authors showed us that renal scarring with VUR is not as common as people are fearing about. The decreased rates of renal scarring was could be secondary to, and hence diagnosis and treatment of UTI was quicker in the emergency room. Antibiotic initiation was quicker in the emergency rooms, and that might have what led to this. But again, they are less common, as shown by multitude of others, from surgeons to pediatricians. Early treatment, as Doganis showed us, also saves kidneys. So if you diagnose within 24 hours and antibiotics was started on a child, within 24 hours of initiation of fever, that avoided renal scarring. So early treatment saves kidneys. So renal scarring occurs in the absence of VUR when we found out that there is an entity called dysplasia and VURD, which is VUR-associated dysplasia. And so those were all bunched up as renal scarring initially. As our knowledge evolved, as more antenatal hydronephrosis and refluxes were diagnosed, we actually found out that these kids were born with some scarring, not necessarily found after a UTI, which would have been the previous instance of our first encounter with the child. So the risk of renal scarring, depending on presence or absence of VUR. So here, this meta-analysis actually shows, yes, VUR does increase scarring, but not in a profoundly significant way. So then, how do we think about this? So then we throw in other factors that comes in here in terms of VUR and VUR resolution, and that being a problem. And most importantly, in the last 2 decades, the biggest idea that's come about is the role of bladder and bladder functionality and how the child deals with the bladder. And that's where comes bowel bladder dysfunction. So if dysfunctional elimination syndrome is on or not, increases the risk of UTI. So here comes another curveball that comes to our way and say, okay, so it's not just the grade of reflux, it's not just the gender of the child, it's not just presence of some previous scarring or not. There's one other element in a potty-trained child, and that's bowel bladder dysfunction. So greater number of UTIs is a little bit more scarring. And so these are, the reason I started with these slides is to say, okay, so I've thrown in all the curveballs and say we have a problem with how do we select our children. But these are some of the cues that we are trying to work out a model in Children's Hospital of Philadelphia about how we think about it. And I'll be very curious and interested to know what your all thoughts are. But basically, in the current day management of reflux, there are a few important factors beyond the factors that we previously knew. And one of them is bowel bladder dysfunction, as we just discussed. And then this factor comes in, which basically says that greater number of UTIs leads to more scarring. And this would have been intuitive, but it's definitely shown here in the scatter plot. So the relationship of UTI and renal damage, and this is the corollary offshoot study of the Swedish reflux study patients. And you can see the number of UTIs increases renal abnormalities, and increased grade of reflux, again, increases DMSA abnormalities. So these two factors drive home. So there is another factor that drives home this story. Abnormalities associated with less reflux resolution. So even if it's a lower grade reflux, the spontaneous resolution rate goes down once the child is potty trained and has bowel bladder dysfunction. The higher grades of VUR now are detected antenatally, given having more renal abnormalities. And this again leads to higher scarring. So this again is an important factor as our 21st century knowledge of reflux evolves. And this is basically our final way of looking at this. So we believe that these are the important factors that literature evidence, as it stands now, takes us to believe. So it's all these are risk factors, these 6 factors that we see over and over in literature has been shown to be a predictive factor for urinary tract infection and hence a recurrent urinary tract infection and hence renal scarring. So what is the target? The target should be exactly the patients who overlap with multitude of these risk factors. This is how you're thinking, but how we can put this in a model? How can we apply this on the clinical bedside for every patient? And is there a way that we can have a scoring way to score every one of these, give weightage to this, and arrive at a renal scarring rate, which then identifies the patients that are going to have that are going to need surgery? So that's essentially a model that we're working on. But at this point, identification of these patients is one of the biggest controversies that we have, and I don't think we have seen. And everybody has their own indication. It depends on which center you land, has their own theory of who to intervene and how to intervene. And hence, this needs to be drilled down a little bit more. So unfortunately, I don't have a clear-cut answer, but we are, as a group, as pediatric urologists, are definitely working towards, from all over the world, are working towards what looks like a destination process. So let me go on to the second, since I've exhausted more than half of my time here. I'm going to go on to the second topic, which I've chosen as a controversy, which was raised by the American Academy of Pediatrics in their 2007 guidelines they came out with, and basically said that they feel that the first instance of febrile UTI does not deserve to have a VCUG, and the second one should deliberate and should demand a VCUG. But in the process of coming to the conclusion, their consensus is to say they put together a few studies and say antibiotic prophylaxis has shown to be not effective in preventing infection, and hence there is no advantage in diagnosing a reflux, because all you're going to do at that point is antibiotic prophylaxis, which in their consensus doesn't work anyway. So prolonged maintenance therapy, this is original Dr. Smelly's paper from England, which basically shows that there was a big difference when antibiotic prophylaxis was initiated, whether the child was observation or was undergoing surgery. There was a significant number of decreasing of events of urinary tract infection after antibiotic prophylaxis. So this is the original paper, and since then, there are a multitude of papers. This is a Swedish reflux study, which actually projected this in a Kaplan-Meier curve, which again shows the significant effect of antibiotic prophylaxis on occurrence of urinary tract infection. Swedish reflux study again shows that the prophylaxis does work, and the prophylaxis does work significantly in girls, and those are pretty dramatic differences demonstrated in the children. Again, evidence to say that antibiotic prophylaxis does work. In their rebuttal for AAP, these are the 6 papers that were taken into account, which basically said, well, prophylaxis does not work. And obviously, they took, and so what essentially they did is they took all their outcomes and bunched together and say, well, we're going to throw all these numbers in together. We're going to come up with an eventual risk factor and eventual p-value values and say if that is not significant, then it should not be. And I'm going to systematically say why they might have multiple problems with their analysis. So problem number 1, circumcision status. These papers were done all over the world, so it's not in one particular society or one particular culture. So hence, it throws a lot of variabilities, particularly circumcision status. We know uncircumcised boys, particularly in the first year of life, are at risk, and circumcised boys are not. So hence, and circumcised boys have a much higher threshold to get a urinary tract infection. One can easily see how a low-grade reflux in a circumcised boy might not skew the curve. And this is the variation between this. And this is where the problem with bunching all these studies come through, because they are so widely different. And here you see the variation. So boys' percentage and circumcised boys' percentage varies so much between these studies. How did they collect a urine culture, and how did they test for UTI? And this back urine specimens were used in the multitude of studies, which again, AUA's guidelines on UTI and diagnosis of UTI pretty much says back urine studies has an 84% false positive rates and has false negative rates as well. Particularly in a uncircumcised boy, it definitely throws a curveball. Age. Again, we know age determines incidence of UTI and problems in the children. Again, a wide variety, and included children who are potty trained, much older, sometimes up to 18 years of age, with no data about bowel bladder dysfunction. We just talked about how important bowel bladder dysfunction is in these kids and how much of a role they play, but then there is no data included in any of these studies. Problem number 4, ultrasound was predominantly used to diagnose if they had a reflux or not. Again, not uniformly accepted. Again, not excellent imaging modality for renal scarring. Problem number 5, antibiotic regimen. Doing the reverse study and in CHOP, the investigators found out that there is a significant reticence about patients and families giving antibiotics on a regular fashion. So they would skip doses frequently. And the only way we found out about that is by doing serum studies to say, are they compliant with treatment or not? And in the reverse study, the compliance rate was 82%. And that's in a watched group, right? So it's not still 100%. And patients know we were checking if they're taking it. And it still was only 82%. God knows what was in all these studies where they weren't watched. So if they're not, if you haven't established compliance, then you can't, the study is not about really whether prophylaxis or not prophylaxis, whether it's about compliance or prophylaxis. The last but one problem is about the study trial design, which again, the optimal should be with some blinded or some placebo control, one or the other, and none of them were either. And then there are a multitude of other problems. So the conclusions that all these studies have, they don't all conclude that there is no benefit. Some of them did, yes. But Montini, for example, concluded there is a benefit in grade 3 and above reflux. Ruzi Kessler basically said prophylaxis may benefit boys with grade 3, just boys. Montini said both boys and girls, and so on and so forth. So the conclusions were not the same, but AAP took it as one conclusion that they all said, don't give antibiotics. And this is what they did. This is what I talked about before. They basically said, this is what we have, and we have a meta-analysis of this text studies, not thinking about any other things in terms of variation of their study effect overall, and they conclude that the p-value is 0.37 with no difference between prophylaxis and not. And this is the famous Yule-Simpson effect we talk about. When you combine data, then you might end up with contradictory results. So here we have, two separate studies on the new drug and the old drug. You combine everybody and then say, well, there is a significant difference between the new and the old. But then if you break out into individual groups that matters, then you say that there is no difference. And this is a frequent thing. People have seen this in multitude of settings, in vaccine trials, and a lot of factors there. So in other words, the antibiotic prophylaxis in our mind, at least in our practice, and it has definitely made a difference. It has avoided many a surgery and many a renal scar, and hence in my own practice and pretty much all of my colleagues, I'm pretty sure, we do BCUGs if the child is significantly ill with the first UTI or if they have dilation, which the AAP conceded anyway. So that's basically where I'm going to stop as two contradictions for VURs and management of patients with such. I don't know how we're taking questions at the end or now, but I'm happy to take another time. Thank you.